Good afternoon, class. We are now going to discuss renal scintigraphy. But before we discuss renal scintigraphy, we have to be familiar first with renal anatomy and physiology. Now here, the kidneys lies retroperitoneally. So this is the kidneys. Okay? So it's behind the peritoneum or the peritoneal cavity. Now, the peritoneum is where the organs are. So, for example, the liver, the intestines, all of the abdominal organs are in the peritoneum. Okay? So, at the back of all those organs are the kidneys. So, this is the reason why you will notice that all scintigraphic procedures, the camera will be posterior. Okay? Because of the location of the kidney. Okay, because the kidney is retroperitoneal. Now, the kidneys lies between T12 and L3. Okay, so here, you will notice that the right kidney is slightly lower compared to the left. Now, this is because of the liver. Okay, the liver pushes the right kidney slightly downward. The urinary system is composed of two kidneys, the right and the left, two ureters, one urinary bladder, and one urethra. Okay, so right next to it, you can see a scintigraphic scan of the kidney so that you can imagine what it looks like. Okay, so here's the kidney, the right and the left. Right, you can see the right is slightly lower. Okay, now sometimes you will see the ureter, but other times you won't. Okay, and this is the urinary bladder. Internally, the kidneys have an intricate and unique structure. The renal parenchyma can be divided into two main areas, the outer cortex and the inner medulla. Okay. The cortex extends into the medulla, dividing it into triangular shapes. Now, this are known as the renal pyramids. Now, the apex of a renal pyramid is called a renal papilla. Now, each renal papilla is associated with a structure known as the minor calyx, which collects urine from the pyramids. Now, several minor calyces merge to form a major calyx. Okay? Now, urine passes through the major calyces into the renal pelvis. So, this is the renal pelvis, which is a flattened and funnel-shaped structure. Now, from the renal pelvis, the urine drains into the ureter, which then transports it to the urinary bladder for storage. Okay? Now, the medial margin of each kidney is marked by a deep fissure known as a renal hilum. So, this is here. Now, this acts as a gateway to the kidneys because normally, the renal vessels and the ureter enter the kidney via this structure. The kidneys are supplied with blood via the renal artery, which arises directly from the abdominal aorta. Okay. Now, due to the anatomical location or position of the abdominal aorta, which if you notice, it's slightly to the left. Okay, the right renal artery is longer and crosses the vena cava posteriorly. Okay. The renal artery enters the kidney via the renal hilum, as discussed earlier. Now, at the level of the hilum, the renal artery forms an anterior and posterior division, which carries 75% and 25% of blood supply to the kidneys. Now, this division is further divided into 5 segmental arteries. Now, these 5 segmental arteries are end arteries. So, what do you mean by that? There are no connection between the the segments. Okay? This is very important because if there is obstruction in one segmental artery, the area supplied by that segmental artery will necrose or will die because there will be no blood supply anymore because they are not connected with one another. So now, class, we will discuss how urine is formed. So let's start first in the heart. So around 5 liters of blood is pumped out from the heart every minute. Okay? Now, that of that 5 liters of blood, 20% of that, around 1 liter or 1,000 milliliter, will go to the kidneys. Okay? Now, of that 1,000 milliliters of blood, 400 of that, 400 ml, around 400 ml of that, will be cells. Okay? Cells meaning red blood cells, white blood cells, blood components, and protein that are way too big to be filtered. Okay? What will be left will be 600 ml of plasma. Okay? Now, this 600 ml of plasma will pass through the glomerulus. Okay? And of that 600 ml of plasma, around 120 ml will be filtered. So from 600 milliliters of blood or plasma that will pass through the glomerulus, only around 120 ml per minute or 180 liters per day will be filtered, and it will go to the Bowman's capsule. Now, you would think that all that 180 liters per day will be the one that will be peed out. Actually, no. Only 1% of that 180 liters per day will be peed out. So, around 1.8 liters per day. Around 99% of the filtered or the filtrate will be reabsorbed. Okay? Now, as the filtrate, so for example, 180 liters per day of filtrate, okay, it will now pass through the proximal convoluted tubules. Now, in the proximal convoluted tubules, around 60% will be reabsorbed. Okay? Now, after the proximal convoluted tubules, the filtrate will now pass to the loop of Henle. In the loop of Henle, around 15% will be reabsorbed. Okay, more on water. So in the loop of Henle, the urine is concentrated. Okay, so water will be reabsorbed. So by the time the filtrate pass through the loop of Henle and goes to the distal tubules, it will be already concentrated urine. Okay? Now, when it arrives at the distal tubule, around 15% of that will again be reabsorbed. Okay? Now, and then after the distal tubules, it will now go down to the collecting duct, okay, where then again another 5% will be reabsorbed, okay, producing urine. So how do we measure kidney function? So we can measure kidney function by knowing the clearance of a substance. So what do we mean by that? So when you give substance A to a patient, we can estimate kidney function by knowing how much of the concentration of that substance or substance A in the urine. Okay? And that will give us an estimate of kidney function. But we cannot use any substance. Okay? We cannot use any substance. What is the ideal substance that can be used to measure kidney function? So first, that substance should be freely filtered. Okay? So meaning, when it arrives or when it goes to the glomerulus, it will be freely filtered out without any problem. Okay? Next, it should not be reabsorbed. Okay? Remember in the last slide that 99% of the filtrate is reabsorbed. Okay? So we want this substance to be not reabsorbed. Okay? Third, that substance that we're going to use to measure kidney function should not be secreted by the body. Okay? So, when all of this criteria or all of these characteristics are fulfilled, we can estimate kidney function by clearance, the clearance of that substance. Because when all of these are fulfilled, clearance will be equal to GFR. Okay? Or glomerular filtration rate. Remember in the last slide, the 180 liters per day? Isn't it that 180 liters per day is not will not be excreted as urine, only 1%? Now, in this case, we want all of the substance to be excreted. Do you understand? So that clearance will be equal to glomerular filtration rate. Okay? Now, what are the substance used? First, creatinine. It is the most commonly used marker for kidney function. But, what's the problem with creatinine? Okay? It's very dependent on muscle mass. Okay, because creatinine is produced in the muscle, or it's a byproduct of muscle degradation. Okay? So it really depends on the muscle mass of the patient. But it is freely filtered, but again, as we mentioned, it is secreted. So it's not ideal, but this is the one readily available for us. So this is the one commonly used. Okay? What is ideal is inulin. Because inulin is freely filtered, not reabsorbed, and not secreted. So as you can see in this diagram, the number of inulin given to the patient, 100% of that will be excreted. Okay? But what is the complication, or what is the problem with inulin? Why do we not use it? Because we need to have a constant concentration of inulin to measure kidney function. What do you mean by that? We need to do a continuous infusion of inulin, which is very tedious and very hard to do. Okay? Now, another way of measuring kidney function is measuring the clearance of a substance that is 100% secreted. Okay? So, why? Because if a substance is 100% secreted, it will give us renal plasma flow. Effective renal plasma flow. Do you understand? So this is an estimate of renal function. Okay. Now, what substance is used to measure renal plasma flow? It is para-aminohypuric acid, or PAH. Because 80% of PAH is secreted and 20% is filtered. Nothing is reabsorbed. Okay? So again, we can use PAH to measure kidney function. Next, we're going to discuss the radiopharmaceuticals used for renal scintigraphy. Radiopharmaceuticals commonly used for evaluating renal function and anatomy falls into three main categories. First, those excreted by tubular secretion. Second, those excreted by glomerular filtration. And third, those bound in the renal tubules for a sufficiently long time to permit cortical anatomic imaging. For radiopharmaceutical excreted by tubular secretion, we have technetium-99m mercaptoacetyltriglycine or MAG3. This is the most commonly used renal radiopharmaceutical. This is highly protein bound, around 97%, and because of this, it is essentially cleared entirely by tubular secretion. Because it cannot diffuse into the extravascular spaces, this leads in high target to background ratios. Although its clearance is only about 60% of that of iodine 131 hippurine, the extraction efficiency is considerably higher than that of filtration agent such as technetium-99m DTPA. Now this leads to excellent performance and less radiation exposure when function is compromised or when kidney function is bad or poor. Flow and plasma concentration or clearance can be evaluated in numerous clinical situations, often interchangeably with technetium-99m DTPA, but only MAG3 can be used to reproducibly measure ERPF or effective renal plasma flow. Another radiopharmaceutical excreted via tubular secretion is iodine 123 and iodine 131 orthoiodohypurate or OIH. It is cleared primarily by the proximal tubules, and the clearance is approximately 500 to 600 milliliters per minute in subjects with normal kidneys. However, this is no longer commercially available in the United States because of the introduction of technetium-99m MAG3. It also has poor imaging characteristic, the potential for delivering a high radiation dose, and the unfavorable logistics resulting from a relatively short half-life of iodine 123. Other radiopharmaceuticals excreted via tubular secretion are technetium-99m LL-NDD ethylene dicysteine or EC and technetium-99m tricarbonyl nitriloacetic acid or NTA, both of which are still under investigation and are not commercially available. For radiopharmaceutical excreted via glomerular filtration, technetium-99m DTPA or diethylene triamine pentaacetic acid is the only radiopharmaceutical available for routine imaging that is purely filtered by the glomerulus. Consequently, it is the only imaging radiopharmaceutical that can be used to measure glomerular filtration rate or GFR. In healthy subjects, the extraction fraction of DTPA is approximately 20%. Now, this extraction fraction is relatively low compared with the extraction fraction of tubular tracers. However, if properly prepared, technetium-99m DTPA is generally adequate to measure GFR clinically. In addition to estimating GFR, technetium-99m DTPA imaging can assess flow and function. Other radiopharmaceutical excreted via glomerular filtration are usually used to measure GFR via plasma sampling and are not used for imaging. These are chromium 51 ethylene diamine tetraacetic acid or EDTA and iodine 125 iothalamate. The next category of renal radiopharmaceutical that we're going to discuss are the ones that are retained in the cortex. Now, there are two radiopharmaceuticals that are commonly used. First, technetium-99m dimercaptosuccinic acid or DMSA. Second, technetium-99m glucoheptonate. Both of these agents bind sufficiently to the renal tubules to permit renal cortical imaging. Technetium-99m DMSA is an excellent cortical imaging agent. Approximately 40% of the injected dose is retained by the renal tubules within 1 hour after injection. The remainder is slowly excreted in the urine over the subsequent 24 hours. DMSA is of particular value when high-resolution images of the renal cortex are needed. It is used primarily in pediatrics to evaluate relative function, pyelonephritis, and renal scarring. Technetium-99m glucoheptonate is cleared primarily by glomerular filtration, but approximately 10 to 15% of the injected dose is retained in the renal tubules, allowing delayed, high-resolution static images to be obtained. It tends to be used for static imaging if DMSA is unavailable, but it should not be used for diuretic renography. Evaluation of the kidneys with radiopharmaceuticals may be performed by using a variety of methods, each providing a slightly different approach to the assessment of renal function or anatomy. This method include the following. First, functional imaging by visual assessment of perfusion and function. Second, renography by time activity curves representative of function. Third, quantification of renal function using GFR and ERPF determination. And fourth, anatomic imaging by visual assessment of renal cortex. Radionuclide imaging with technetium-99m labeled agent provides anatomic, functional, and collecting system patency information. Imaging may be adequately performed in most patients by using either technetium-99m mag3 or technetium-99m DTPA. Functional imaging of the kidneys may be divided into two: renal perfusion and renal functional imaging. Normally, both kidneys can easily be imaged on a standard or large field of view gamma camera with a parallel hole collimator. Image information is usually collected in digital dynamic mode or on an interface computer and reformatted in temporal sequences that reflect both initial renal perfusion and subsequent function. Imaging renal perfusion is usually began as the bolus is visualized in the proximal abdominal aorta, with subsequent serial images made every 1 to 5 seconds, depending on the instrument available and the preference of the interpreter. So you can see here, after injection, you will see the abdominal aorta. Now, after 2 to 3 seconds, you will see the kidneys. Okay? Here. Time activity curve reflecting renal perfusion during the first minute may be generated by drawing region of interest over the aorta and each kidneys. Now, each of the renal curves may then be compared with the time activity curve of the abdominal aorta to assess relative renal perfusion. Generally, renal peak activity during the perfusion phase equals or exceed that of the aorta and should be reasonably symmetric between the two kidneys. Aside from the time activity curve, perfusion index may also be generated. Now, perfusion index is an evaluation of choice in transplant kidneys. It actually measures the amount of tracer reaching to the kidney through the blood, and it is a tool for assessing renal function. Now, there are two commonly used indices or perfusion indices. First is the Hilson Perfusion Index, which is the ratio of the area under the aortic curve divided by the renal perfusion curve. And second is the Kirshner's Ka ratio, which is the ratio of the slope of the maximum upstroke portions of the kidney and the aortic curves. At the end of the renal perfusion sequence, imaging for renal function begins. During the initial cortical or nephrogram phase, the kidney accumulates activity for the first 1 to 3 minutes, and the collecting system is either not seen or slightly photopenic. Peak overall activity should normally occur by 4 to 6 minutes. The kidneys should be symmetric in size. During the clearance phase, activity moves from the cortex into the collecting system and is excreted into the bladder. Normally, the calyces and pelvis usually begin filling by 3 minutes and ureters or bladder by 5 to 6 minutes, with the collecting system activity decreasing through the final clearance phase. Given the variability of peristalsis and other factors, the normal ureter may or may not be seen and may appear as a thin column of transient activity. The next is renography. A renogram is simply a time activity curve that provides a graphic representation of the uptake and excretion of a radiopharmaceutical by the kidneys. Information is displayed from the time of injection to about 20 to 30 minutes after injection. The classic renogram curve is obtained by using agents that are eliminated by tubular secretion, such as technetium mag-3. Renogram curves are generated by placing a region of interest around each kidney, usually the entire kidney, but occasionally just around the renal cortex. Background subtraction regions of interest are selected just inferior to each kidney. An aortic region of interest may be used to assess the discreteness and adequacy of the injected bolus as well as relative renal perfusion. The normal computer-generated renogram curve using a tubular radiopharmaceutical consists of 3 phases. The initial renal perfusion or the vascular transit phase lasts about 30 to 60 seconds and represents the initial arrival of the radiopharmaceutical on each kidney. As discussed earlier, reconstruction of the first 30 to 60 seconds of the curve by using different indices may be performed to assess more carefully the renal perfusion phase. The second phase is the cortical or tubular concentration phase of the initial parenchymal transit. This phase occurs during minutes 1 through 5 and contains the peak of the curve. The initial uptake slope closely correlates with ERPF values. The third phase is the clearance or excretion phase, which represents the downslope of the curve and is produced by excretion of the radiopharmaceutical from the kidney and clearance from the collecting system. This is an example of a normal renogram. As you can see, are the phases of the renogram. First is the vascular phase, next is the cortical phase, and lastly, the excretion phase. Okay, as you can see here, both kidneys have normal renograms. Also, take note of the bladder activity. Okay, as you can see here, as the activity in the kidneys diminish, you will notice a increase or an upslope in the bladder activity. This represents the entry of the radiopharmaceutical from the kidneys to the bladder. There are several semi-quantitative indices that may be derived from the curve. Now, as renal function deteriorates, delayed transit of the radiopharmaceutical in the kidney results in an abnormal renogram curve, which can be quantitated by using these indices. First is the time to peak activity. It is simply referred to the time from radiopharmaceutical injection to the peak height of the renogram curve. Normally, it's about 3 to 5 minutes. The relative renal uptake ratio at 2 to 3 minutes, this is the index of relative renal function between the two kidneys. Activity in each kidney should be equal, ideally 50%. A value of 40% or less in one kidney should be considered abnormal. Half-time excretion or T-half is the time for half of the peak activity to be cleared from the kidney. It is around 8 to 12 minutes. Differential cortical retention at 15 minutes. The percentage of retained activity about 15 minutes after injection in each kidney should be relatively equal. Differences of 20% or more should be considered abnormal. Lastly, the 20-minute to peak count ratio. This is the activity measured in each kidney at 20 minutes and expressed as a percentage of peak curve activity. In the absence of pelvic calyceal retention, or if only a cortical region of interest is used, a normal 20-minute maximal cortical ratio for MAG3 is less than 0.3. Next, we're going to discuss quantification of renal function. The most common measure of renal function in clinical practice is serum creatinine. However, the problem with serum creatinine is that it's affected by several factors: muscle mass, diet, and age. Another problem is that half of the renal function must be lost before serum creatinine level becomes abnormal. Now, measurement of creatinine clearance using 24-hour urine collection is cumbersome, inconvenient, and often unreliable. In a study, repeated measurement in stable patients have shown a disappointingly high 25% coefficient of variation. Another way is to use the formula for creatinine clearance, such as the Cockcroft, Gault, and the modified MDRD. Now, this is based on the patient's age, body weight, and serum creatinine. Now, with this equation, however, 20 to 30% of subjects have an estimated GFR outside the relatively large 30% accuracy range of the measured GFR. So, it's not that precise or reliable. Direct measurement of GFR and ERPF by using radiopharmaceuticals play an important role in the assessment of renal function. Quantitative assessment of renal function by using radionuclide technique is an important part of nuclear nephrology, and it's routinely performed in some clinical settings. There are two dominant radionuclide methods of determining eGFR in ERPF. First is the plasma sample-based clearance, and second is the camera-based clearance. For plasma sample-based clearance, these measurements are generally obtained by determining the plasma level of the injected radiopharmaceutical at a specified time. For tubular agents such as MAG3, ERPF can be estimated by a single time blood sample obtained about 45 minutes after injection. Because the glomerular agent DTPA is cleared more slowly than our tubular agents, plasma samples are obtained 60 and 180 minutes after injection. The amount of activity remaining in the blood at these times is a measurement of activity not yet cleared by the renal mechanism and therefore is indirectly a measure of activity already cleared. This technique requires meticulous attention to detail and personnel expertly trained in vitro techniques. When performed correctly, GFR and ERPF measurements are theoretically more accurate than are those based on camera measurements. For camera-based method, calculations are made by using counts acquired from the syringe containing the radiopharmaceutical before injection and subsequent counts over the kidneys after injection. Commercially available software for camera-based clearance simplifies corrections for patient and acquisition variables and provides reasonably accurate computer-derived clearance value. Although camera-based clearance are not as accurate as are those based on plasma samples, they are highly reproducible and sufficiently reliable to be used in clinical practice. Lastly, we're going to discuss anatomic imaging via visual assessment of the renal cortex. Renal cortical imaging is usually performed for evaluation of the space-occupying lesion functioning pseudotumors such as cortical columns of Burton or edema or scarring associated with acute or chronic pyelonephritis, especially in children. These images of the renal cortex are generally taken by using technetium-99m DMSA or technetium-99m glucoheptonate and by using a pinhole or a high-resolution collimator or a SPEC. After injecting the radiopharmaceutical, imaging is generally done after 2 to 3 hours to allow for the relative slow background clearance. This is the end of the first part of our nuclear nephrology lecture. Tomorrow, we will discuss the specific protocols for dynamic or functional imaging and static or anatomic imaging.